But I'm telling you, this surgery is not in your book, but you're gonna see this surgery in the hospital. Because they do it all up and down the Gulf Coast. So we're gonna talk real quick about hemorrhagic stroke, because there's not a lot of stuff we can do for this patient other than treat their symptoms and modify some lifestyle choices. So, medical management and surgical management. There's no effective targeted therapy, just like the TPA for this guy. So here's our picture of the circulation of the brain. If I have a nice big bleed, the most common place is the right middle cerebral artery and the left middle cerebral artery. Can you see how that makes a significant place on the brain? Then your patient's gonna have some deficits. Right here, this is the most damaging place to have a bleed because it affects the blood flow to the rest of the brain. So that's the most dangerous place. Here's the picture of that AV malformation. See how this is normal up here on top? This is all just mixed together, and you have venous and arterial blood together, and eventually the vessels get weak and they'll burst. That's your aneurysm right there where it balloons out and that will burst and they'll have a bleed. A lot of times a patient has a fall or something, like they can have the aneurysm for a long time and not know it till they have a fall. So basic life support, reversal of anticoagulants. Let's talk about that one first, okay? What am I gonna give to reverse warfarin? Okay? If my patient's had heparin, what am I going to give? Fermium sulfate. If my patient has any of the new blood thinners, Eliquis, Savasa, there's no reversal agent for those. You gotta wait till they wear off. So that's the one drawback of those drugs. The positive thing is you don't have to go have blood drawn to get lab levels all the time. They're expensive, but there's no reversal agent. I don't want this patient to have a seizure. So, does my patient who have a stroke get a prophylactic seizure medication? Okay, your book says they don't. I'm just going to tell you right now, your book says that it's not routinely given, but I can tell you in practice, it is routinely given. All those patients that we have on that stroke floor down at Memorial, they're all on some sort of anticonvulsant medication, even though they have no history of stroke. So that's a discrepancy right there. I want to ask you something where I know there's a discrepancy that you're going to see in practice. If my patient does have a seizure, what do I want to do about it? Okay, first thing, I want to make sure they're safe. And usually, I wouldn't give anything to stop the seizure on a normal patient unless it was over 5 minutes long and I had status epilepticus. But because every time this patient has a seizure, it increases their intracranial pressure, I want to stop the seizure. So what meds do I use to do that? What did you say? The benzos. So lorazepam and diazepam are the drugs of choice that they use. Then they start them on either Keppra or phosphatoin. Does Keppra and phosphatoin stop a seizure mid-seizure? No. I gotta stop it with the benzodiazepine, and then I'm gonna give prophylactically the anticonvulsant medications to prevent them from having another seizure in the future. Phosphatoin. That's a synthetic form of Dilantin. Blood pressure control. I have a bleed in my head, so I want my blood pressure to be high.
No.
Do I want my blood pressure to be too low?
No.
No, because I still have to have cerebral perfusion pressure. And if my blood pressure is too low, I'm not perfusing my brain. So they're going to really watch blood pressure and make sure that it's perfusing the brain, but not too high or too low. We're going to talk all about this ICP stuff in level 4, so please don't get lost in all the details in that chapter on critical field patient, okay? Yes, they might give mannitol. Mannitol is really a fluid issue thing though, not a blood pressure issue thing. Constant hemodynamic and neuromonitoring. Bed rest. Why do I want them on bed rest?
Don't want to increase their ICP.
Right, ICP, I don't want to increase their ICP, and I also don't want them to fall, and until I know what the cause is, I don't want them on the floor, because if they hit their head, I'm going to have a bigger bleed. We already talked about fever and temperature control, because a fever raises the metabolic needs of the brain, and in the process raises their ICP. Electrolyte and fluid imbalances, can that cause anything to happen in my brain?
Seizures.
Yeah, so I'm going to correct those if they're correctable. Really, all I'm doing is I'm looking for problems and correcting problems. I can't really do anything for this patient except keep secondary problems from happening. Hyperglycemia. What do you know about hyperglycemia? Okay, it irritates the vessels. The problem with this here, hyperglycemia here, is you're going to learn in level 4 with DKA that it causes your patient to have respiratory alkalosis. And so if I have that problem, then I'm going to, I need to keep the blood sugar within the normal range because I'm preventing another problem with my brain tissue. Maintain hydration. How am I going to do that? My patient can't eat anything, they can't talk, they can't move. IV fluids.
3 liters a day?
2 to 3 liters a day, depending on your patient. And I say that with caution, depends on your patient's health history. Because do I really want a CHF patient getting 2 and 3 liters a day? No. Manage hypertension with IV medications and H2 blockers. Why is he getting an H2 blocker? Yeah, we're trying to prevent him from getting a stress ulcer. So everybody in the ICU is going to get some sort of an H2 blocker, usually IV Prilosec or something like that. And then, what about sedation? He has a hemorrhagic stroke. Do I want him sedated? No. I don't want to sedate him unnecessarily. If he has to be on a ventilator, might I have to sedate him? Yes. Yeah, if he's combative or on a ventilator, I might have to sedate him. But we talked about that the other day, how we can reverse that so we can still do an assessment. Huh? Rabazicon, yeah. So hemorrhagic strokes is the only stroke that has vasospasm, and that's why they usually complain of a headache. And that is treated with this drug right here, nimodipine. What kind of drug is that? It's calcium channel blocker. So what does it do to the blood vessels in your head? Okay. But what does calcium do to the vessels, the vessel walls? It relaxes the vessel walls and prevents that vasospasm from happening. So that's why they use nimodipine is the only one that's approved to treat the spasms associated with the hemorrhagic stroke. Hydrocephalus, we talked about that a little bit the other day, too much cerebral spinal fluid. And if your patient's severe enough, they're going to do a ventriculostomy and pull off some cerebral spinal fluid. Hematoma evacuation, how am I going to do that? Cut open your head, do a craniotomy, and pull the clot out. Surgical clipping is what they do for an aneurysm. So when you have that, let me go back to the aneurysm. So what they do is they take a metal clip, and they just clip this off. And so if you clip it off right there, this is eventually going to die. And so that weakened part of the vessel is not there anymore. What do your patient need to know if they do the surgical clipping of that? Okay, initially, yes. MRI is the most important thing. A surgical clip is metal. And so they need to know that they can't have an MRI again because they have a metal. It stays there. It stays there. And then with your AV malformations, they go in there and they, hold on right there. The coil embolization, they just go in there and that whole mesh of artery and vessels together, they embolize that so the blood doesn't flow through there. Does your brain, can it make collateral circulation? Yes. Yeah, just like your heart. So they just cauterize that and get rid of it. Then the stereotactic radiology, what does that mean? What's what's that mean? Okay, it's not really surgery. It's when they take your head and they put it in that big thing so you can't move, and they go in there with a radioactive beam and they clot off the blood vessels that way. The problem with this is you don't see the results of that for a good 2 to 3 years, like the final results. So it's not super effective in an acute bleed. But if your patient has the AV malformation with no problems, they could do that and
And for the clipping, you said it stays in there, but it's ever removed, like after the tissue dies?
Yep, stays there. Clots that off and stays there. So I gave you the slide right here with what the parts of the brain do, so that you'll have that, because I'm just gonna tell you, that's something you just gotta have to memorize. Nothing, I mean, we can talk about it all day long, but if you don't memorize each part and where it is, you'll get questions wrong, I promise. You talked about this yesterday at the ASLS. So if I have a patient who has a right brain injury, and I look at these things right here, what's that patient look like? What's the patient, what do they like personality-wise? They're super impulsive. That's the patient that you tell, do not get up to the bathroom without calling me for help, and before you can turn to the door, he's already climbed over the side rails. He forgets. They think that they can do everything they used to do because they don't remember. They're very impulsive. Your left brain injuries, they're very cautious. You want me to walk down the hall? They're hanging on to the side rails, you know, because they're afraid they're gonna fall. Super cautious. So you just need to, this is another slide that you just kind of have to memorize, left-sided and right-sided, and what the deficits are. Does that make sense? I mean, I can tell you all day, but if you don't memorize it, you're not gonna remember it. I usually don't tell you to memorize stuff. You know that. Let's talk about modifiable and non-modifiable risk factors for strokes. Can I modify my age?
Nope.
I would say, can I modify my gender, but that's not a good question, because I could modify my gender if I wanted to. But the gender, I can't modify my family history and my genetics, you know? The geographical location, I put that on there because we do live in the stroke belt, but let me ask you a question. Could I modify that if I wanted to?
Absolutely.
I could move away if I wanted to move away, but, you know, I'm not going to. I could quit eating fried chicken if I wanted to, but that is modifiable. I'm gonna say it's non-modifiable, because my livelihoods here, I'm not going anywhere. Modifiable though, hypertension, is that modifiable?
Yes.
Yes, I can modify that by taking my medications, by my diet, exercising, other things that modify it. AFib, I'm always gonna have it. Is it modifiable?
Yes.
Yes, if I treat it. So I can have AFib that's treated that doesn't have the complications. Coagulation disorders. I can't modify things like hemophiliac, but can I modify things like taking the medications?
Yes.
Yeah. Oral contraceptives. They put me at a higher risk for strokes and blood clots, so I have to weigh the options. Do I want a baby or do I want to have a blood clot? I mean, that's really different.
Baby's permanent.
But that is modifiable. If you know you're at a higher risk. Let me ask you this. If I take oral contraceptives and I smoke,
Even higher risk.
did I just double my risk factors? I sure did. If I'm a diabetic, is that modifiable?
Yes.
I'm always gonna be a diabetic,
Well, you can take your
but
meds
I can control my blood sugar.
and your diet.
And what am I talking about when I say lifestyle factors? Smoking, diet, exercise,
Eating chips.
so those kind of things. Here's our ABCs. The antiplatelet drugs, aspirin or Plavix, go home on. You got all of these anticoagulants here. We talked about the benefits. Warfarin is cheap. It's been around forever. But you have to go have labs drawn. But you old people living on a budget, you know what I'm saying? Most of them are gonna, their insurance is gonna pay for the blood draws, and the medicine's cheap. These medications are a little more expensive, they're super effective, but there's no antidote to those medications. So depending on my health history, let's just say I have a history of diverticulitis. I have a friend who has diverticulitis. She's had surgery and had a colostomy at one time, had it reversed, all kinds of GI problems. Are these drugs good for her? No. Nope. She takes warfarin for her AFib because if she had an emergency that had to have surgery, they could reverse it.
So that's the most commonly used one.
It is the most commonly used one, mostly because it's cheap, and the insurance will pay for your blood draws, or Medicare will pay for your blood draws. So let me ask, I had a question written down about one of these drugs. Where it went. Your goal blood pressure, 130/80. Is that the goal for the average person? No, but that's a goal for a person who has any kind of cardiac disease or any kind of stroke. They don't want it to be over 130/80. We talked about taking the statin medications and stopping smoking. Y'all just need to stop smoking altogether, I'm just saying. But smoking is a huge factor in cardiac and cardiovascular disease. The diet, what's the Mediterranean diet?
Lots of vegetables, fruit, raw meat, lying around and feeling it, and then, I put my boyfriend on that, he doesn't know. He's got, all risk factors and things.
He knows we're cooking, but he doesn't eat it though, right? Good fats or bad fats? Can I eat fats on them?
Yeah, like avocado,
Yeah.
olive oil,
Olive oil, avocados, I can use the good fats on that. Exercise, 30 minutes of moderate intensity physical exercise a day.
Like you don't know it.
So let me ask you a question. Is moderate intensity the same for everybody?
No.
No. Because if you have somebody who's been inactive for years, just going to the end of the driveway to get the mail could get their heart rate up and be considered moderate intensity. So if somebody who's super active, if you say, well, we're just gonna go walk the bridge, they'll be like, walk the bridge, you know, I run 10 miles a day, you know. So that depends on your patient's physical
I'll be
abilities.
walking halfway.
We already talked about, did we talk about brain tumors the other day? We did, yeah.
Well, I guess we did.
So rehabilitation, speech and language therapy. Your speech therapist is gonna do your official swallow study for your stroke patient. We're gonna keep them NPO until they do that swallow study, according to your book, okay? We know that in real life, the nurse is gonna do a bedside one. They're gonna help you with, this patient's speech and with their swallowing and things like that. Let's talk about these diets real quick, because you know all of them. Terms associated with communication, apraxia and dysarthria, that has to do with the muscles and forming the words and the motions to make the sounds, okay? Aphasia has to do with the speech itself and usually comes from some sort of brain injury. And then your patient can have cognitive deficits. Can I have a language problem if I have Alzheimer's? Yeah, I can eventually have a language problem. I can have a swallowing problem if I have Parkinson's disease. So these apply to all of those patients that we've talked about in the past. What's the difference between Broca's aphasia and Wernicke's aphasia? Okay, Broca's is expressive, so the patient can't get the words and what they're trying to tell you out. Wernicke's is receptive. They don't understand what you're saying. Don't tell anybody, you know, like that. I'll let her back in though. You know, we're gonna go in my teaching places. What's below your face? Both. It's a combination of both. Very, very frustrating for the patient. Very, very frustrating for the caregiver. It's a combination of both. Modified diets, we talked about these in level 2. We can modify their diet by the food, the consistency, the temperature, and the texture. we can alter the size of the bite that the patient puts in their mouth. Does that make a difference? Yeah, I have an 11-year-old grandson. No, he eats like you're gonna steal his food. And I mean, he eats so fast. Sometimes you just have to remind the patient,
Breathe.
you need to slow down. You need to chew that bite and swallow before you get the next bite in your mouth. And there's nothing wrong with him mentally, he just eats fast. He says they get 10 minutes at lunch. He learned that at school, he said. Positioning and posturing. How do I want my patient position to eat? High fowlers or up in the chair, even better, especially if they have any kind of known swallowing problems. My physical therapist can teach them different swallowing maneuvers, the chin tuck, or things like that, and they also can teach them exercises for chewing and using their tongue to move food around in their mouth. Do I need to be checking to make sure my patient's swallowing?
Yes.
Yeah. Before I keep shoveling it in, I may need to make sure it's not pocketed in the side of their cheek somewhere. I told you already, I hate feeding people, just so you know.
Me too.
It takes too long. I'd rather bathe 10 people than feed one. Feeding methods, I can do intermittent, or I can do it on a pump. What's the benefit of the pump?
You don't have to sit there.
I don't have to sit there, it's continuous. I just put it in the bag and set the pump correctly and move on. What's the benefit of the bolus? Okay, and also, not only that, not only can I titrate it, I can mimic mealtime. So my patient doesn't lose that desire to, lose that hunger and desire to eat. So I can mimic mealtime. The other thing about continuous is, if you just start a patient on continuous, when they start it at a real low rate, like 20 cc's an hour, with a goal of 65. Why do they start it so low? I want to make sure they can tolerate it, they have GI function, but it gives, if you start it too fast, too quick, it'll cause diarrhea. And so they start it at a low rate and bump it up to the needs. Who calculates how much the patient needs per hour? Dietitian. You know all about feeding tubes and short-term nasogastric tubes, but I put a slide on there. Just gonna tell you, this is not in the book about head injuries, it's in the book about GI diets. If you want me to, I'll go back and put the charts that you need to look at in the PowerPoint. The benefit is of tube feeding, it's cost effective and it's safe. It preserves your GI integrity, because remember, if you don't use it after a while, it's just gonna stop functioning. So it does that. It helps maintain normal blood glucose levels and metabolism. Thicket. Anybody use Thicket in the hospital? All the time. If I put it in my drink and I let it sit there, what happens? It gets thicker and thicker. So you need to make sure that you're mixing up what the client needs at the time and they drink it. Honey thick, just exactly what it says. If you put it on a spoon and you tip the spoon, it pours off like honey. Spoon thick is like pudding consistency. I honestly don't know how this quenches anybody's thirst, but if you can't swallow, you're gonna do what you gotta do. Then we have the nice fancy trays that they send up that are supposed to look like the food that it is.
Good.
What's the difference?
Dang it.
This one is completely pudding consistency, and this one can have small, semi-solid pieces in it. So this could be something like chicken noodle soup. It's soft that they can get down, and this is completely full. Yeah, like mashed potatoes, pudding,
in your brown.
grits falls in this one. And then what's a soft diet? They usually call it mechanical soft in the hospital.
Easy to
Easy to chew. So if you get a hamburger, it's chopped up in tiny little bites.
It's like a toddler nut.
Yeah, like a
Toddler diet.
exactly, like toddler diet. Any questions about the modified diets? What can I put thicket in?
Lukewarm.
Pretty much anything. I can put it in juice. It's not really recommended to put it in soda, anything that's carbonated.
No,
Yeah,
No
no
ice.
ice, because what happens
When
when I
it-
drink,
It'll melt and it'll get
it's
thin
gonna get
again.
diluted as the ice melts. It won't be the same thick and consistency.
Yeah,
He
that's a
works
hobby.
here. He works here, I'm just telling you. I'll tell you how I know it, we'll take a break. I had a patient at Kiesler, he was dying. I don't know what he had wrong with him, but his whole gut was held together with a wound back. He had a trach that he pulled out every night, and he had a feeding tube, but he could have thickened liquids. Well, one night he was just in a terrible mood. And I said, what is wrong with you tonight? I said, why are you so mean to everybody? And he said, I just wanna watch a baseball game and drink a beer. The guy's dying. So I called the doctor and I said, could he have a beer? And of course I got the runaround at first, that it had to be thickened and stuff. Okay. Well, he can thicken a beer. And you can make your patient very, very happy. And the next day when I got back, he had 3 beers a day ordered. But you can thicken almost anything. They don't recommend it for carbonated beverages, but it does work. So take a break, y'all. Come back at 5